through with this. So we started 20 gauge, 23 gauge, 25 gauge, and now of course we have the 27 gauge. Pretty much 25 gauge is good enough to all the work which we are currently doing with the 23 gauge. I don't have too much experience with the 25 gauge because the equipment which I use does not support the 25 gauge. This is one of the very few gauges which I have done. So you can segment, you can bead, you can delaminate, pretty much do everything just with the cutter itself. So 25 gauge does do probably about 80% of what you can do with the 25 gauge. So what you're seeing here is the segmentation. All these steps the previous speakers have very elegantly shown. So peel it and then remove it. Pretty much delamination can be done with the 25 gauge. So you can cut very close and remove the tissue. And one other concept is to identify the second membrane. The second membrane is the membrane which extends anterior to the visible fiber tissue. You see that second membrane. So Dr. Mahesh was mentioning about outside in surgery. Once we identify this second membrane, then we are in the correct break. Then everything comes into the cutter very, very easily. And without causing any iatrogenic breaks with very, very minimum risk of bleeding, we can share all the fiber tissue. So that is 27 gauge surgery. So once again, when you experience the 27 gauge, probably Dr. Mahesh and others who use Alphon may have. So it has for 80% efficacy of the 25 gauge cutters. The other problem is the illumination. So with the use of mercury and xenon, we are able to have adequate illumination with the very, very thin probes. But the issue is these are very, very, very labile probes with a very thin probes which are good enough to cut thick fiber tissue is something which we don't know. Cutting rates, once again this was touched upon. The norm right now is 2,500 cuts to 5,000 cuts per minute, 7,500 is possible. And this normal cut which has come up, this is called the back to razor blade which we have. But here, this cuts on both ends. Usually cuts only one end. Here they have made this on both ends it cuts. So when it cuts and it comes up, it cuts. So that way just going down and coming up, it cuts twice. So that is a newer concept which has come up. And the is open most of the time. So there is one modification of the cutting blade which has come up now. But then what is the role of the increased cutting? Because the thicker fibrous tissue, just like how we are trying to remove a thick lens, we need a cutting higher suction. So a thicker tissue, we may not be able to penetrate. So we need a lower cutting rate. So the cutting rate is to decrease the traction, but when the but in TRD or a couple DRD make less sense. So is there any view? So laser vitrectomy is something which is very, very attractive. So we don't suck and pull. With loss of cutting, can we suck the retina inside and chop it off? So that's something which may not be possible, which is something which you can avoid with the laser vitrectomy. This is a picture of a laser probe which was introduced 20 years back. So the laser kind of comes at right angles and there is a port which sucks subsequently with vaporized tissue. So this cauterizes as it cuts, thereby decrease the risk of bleeding as well. So this was something which was introduced 20 years back. So why they started on it futuristically? The problem why it didn't catch up was that the probe was large size and the rate of cutting and sucking was also slow. And the fiber optic which connects the laser machine to the probe was bulky and expensive and it was not very, very, very flexible. So it didn't become very, very popular. And the depth of thermal damage where the laser penetrates into the retina was something which was uncontrolled. So inadvertently we were damaging the retina wherever we were cutting. Cutting rate was limited by vaporization bubbles. Wherever we were cutting, bubbles were coming out. So we had to stop the bubbles and then proceed to the surgery. That's why it has become popular. Now, probably a couple of months back, there is a new interest. So they have modified the probe by adding these microspheres here. So these microspheres tend to focus the laser exactly at the tip. So thereby decreasing the damage to the retinal tissue. So there is a prototype probe. The advantage is we can just remove this part of the probe and replace it. So the most expensive part of the fiber optic we can retain, and only the tip can be replaced, and there is a cut section. So this has the size of the sapphire microsphere, and it also has inbuilt illumination. So you can also see and also cut using these probes. And because of the arrangement of these probes, a less powerful laser can also be used, and laser penetration is only 10 to 30 microns. So this way we should be able to use laser to cut safely without damaging the tissue, and also use a very, very less powerful laser and a kind of reusable cut, just the tip can be removed. So this is just about carbon. So it's tested in animals. So it has to like probably expect the next next 5 years, we should be maybe using the laser with dental vision. Here is once again a picture which one of the speakers showed. The cannula visco to fibrous tissue off the retina, and to make this injecting visco visible, you can conjugate it with PVG. So that way you know where the visco is concentrated concentration point. But I really don't need the point of it. This is again a retinal attachment. You see anterior, there's an invisible tissue. So once that is complete, the whole fibrous tissue will get into the pattern. So most of the times, or rather I seldom use this visco dissection. So if we go anteriorly identify this second membrane and peel it towards the posterior pole, then all this fibrous tissue does come in very, very easily. So the visco, if in case we want to use the visco dissection, this is a instrument which is currently being available. So all of us have been doing this surgery of creating the posterior hyoid opening and then cut it off. And if you see carefully, there is one attachment out here. So that we may at times not be able to identify this, or we may have seen it in the preoperative OCT, but during the surgery we may not be sure where it is coming in and how we go about it. And after we remove this also, we don't know if we have left something behind. We can use dyes as well. So in those situations, something which is coming up is the ability to do an OCT intraoperative. So there is a probe which is available, pretty much like a vitreous probe. You put it inside the eye and you can have a live OCT. So a similar OCT is available built into the microscope as well. So you're just going to come up. So you can have an OCT built into the microscope as you're operating, you can see what's at the macula, or you can use a vitreous probe, put it inside and see how the probe is, how the condition of the retina is, and then tackle it. Get another condition where the patient has bronchial diabetic retinopathy, a central macular hole, and a combined retinal detachment. So you usually use BBG or you use triamcinolone to identify the hyaloid, remove it. A modification of this is a color illumination system. Instead of using a white light or yellow light, use a green light. So here, but you can see the area of ILM and its complete. So you can use colored illumination systems to identify the ILM and remove it instead of using the dyes. So different colors give different approaches. Like you can identify different structures in the retina differently by using colored illumination systems. But I was sincerely hoping that we don't have to do at all a vitrectomy for a diabetic problem. So if the patient with a diabetic retinopathy, given the stage of an NPDR, create a PVD. So this patient has decreased risk of developing PDR, decreased risk of developing TRD, decreased risk of developing CRD, probably less problematic macular edema. I was hoping that mycoplasmin will help, but then it doesn't seem to be the condition. So even in a simple VMT, only about 50% of the patients will be helped, and a patient with macular hole, only about 30% will be helped. So this is a simple patient with no strong nails which are pulling the vitreous back to the retina. In such a situation, I don't see this replacing a vitrectomy. So we really need to have something else which cleaves the lamellin and fibrinogen much better from the retina and it is the PVD. Probably, I don't know if when it will come. If it comes, then probably we can stop doing vitrectomy for diabetic vitrectomy. So this is my wish list. I wish there was a man. This is a patient where dissected extensively and then they start bleeding. Then blood clot appears there. And the process of trying to remove it, we create things. So these are however meticulous we are, however bimanual surgery we do. Our labile diabetic who is a type 1 who is sick, nephropathy will undergo this. There were answers for this patient also, where we have done extensive dissection. Every bit of fibrous tissue has been removed, and then they come back 6 weeks later with extensive leak clot. Again, these are sick patients who do have a very systemic condition, then they come up with this. And then the patients who present with disease, this because whether to do or not is often the walking eye of the patient. But then you can go ahead with existing, you can see all sclerosed plus failed disc and the one eye of the patient. We can go ahead with this existing technique and results like this so that I'm gratifying. But then we have patients like preoperative 624 or 624. We have a disc panel of vessels. These patients have not had Avastin or whatever to say or a traumatic surgery. Again, this is a patient like this 624 and then at the end of the surgery 636 discontinued pain. So these are patients who have not had elevated IOP without any, just go ahead with the surgery and then subsequently they will go down like this with or without oil inside the eye. So wish there were, like something comes up for all these patients. So what are we looking at in the future? We will continue to do vitrectomy for diabetic retinopathy, contrary to whatever we are thinking. Equipment, some improvements expected in the future like what I have shown, maybe a laser probe, maybe some other better techniques of cutting. But the techniques, as all of us have shown, we continue to evolve. We learn from each other and continue to evolve. Thank you very much.